Dr. Alejandro Elorriaga, MD, sports medicine specialist, and program director, has consulted in sports medicine for 33 years in Spain, Canada, and internationally, providing performance care and injury care to professional athletes and private clients. For the last 25 years, he has taught hundreds of postgraduate courses in neurofunctional acupuncture and the functional assessment and manual treatment of musculoskeletal problems and sports injuries. He has made professional presentations all over the world. Dr. Elorriaga's scientific background includes over 13 years of research and practice in the areas of exercise, physiology, and neurofunctional electroacupuncture. Since 1995, Dr. Elorriaga has been developing original neurofunctional electroacupuncture and original manual techniques for the integrated treatment of sports injuries and movement disorders, as well as the restoration and protection of athletic performance, a novel technical approach named performance care. So I wanted to let everyone know that he'll have a presentation, and if there are any questions, we'll hold those to the end. But if you could type them in the Q&A panel below, I will read them, and we'll have a bit of a discussion with Dr. Elorriaga at the end of his presentation. So welcome. I'll hand it over to you.
Thank you. Thank you for the kind introduction, and thank you so much for the invitation to share some of the methodology that I've developed over many years of work with the audience. As you mentioned, and I'm going to start sharing the screen or the PowerPoint presentation. As you mentioned, when I was preparing this and was trying to create some background information, quickly I realized that I needed to spend few hours before I could go to a real case presentation with the guarantees of people understanding truly and profiting from it. This morning, I saw a couple of patients in one of my instructor's clinics, and in doing so, I had a couple of top instructors here. I explained to them some things. I asked some questions while I was doing the treatment, and then I realized once again that the subtleties, the nuances of a neurofunctional approach are definitely something to keep working at. And what I like is you to be able to fully profit from this approach and to convert you, if you're not there yet, into a neurofunctional practitioner. So the ultimate goal of the presentation is to teach you or to help you learn rather than teaching you, because again, there's not, I'm going to share and teach a little bit, but also I'm going to point in directions so you can pursue and explore those topics yourselves. So I like you to understand how to analyze and how to treat neurofunctionally, and we'll explain that time and again. And for that, today's focus is to start revealing the science-based secrets. They're not truly secrets because they are available to everyone, but nobody's put them together in a way that allows to progress from a foundation to an advanced level in the neurofunctional analysis and treatment of pain with movement. And I will attempt that in the next so many hours, how many it takes to cover the whole material. That's my commitment to you. That way I can go at a comfortable pace without having to skip any of the many valuable pieces of knowledge that I'm going to share with you. So at the end, we will apply that knowledge to some cases, probably more than one. And you will then fully understand the strategies behind these pictures, which are all from real cases. They are also old cases, over 20 years. This is Sydney 2000, this is Athens 2004, this is Paris 2003, this is Edmonton 2001 World Championship, this is Seville. So I was fortunate enough to work with the best track and field athletes in the world from 1995 to 2005, a decade. I did 6 World Track and Field Championships and 2 Olympic Games. And I learned through working with these athletes, many of the techniques I developed the techniques, and ever since the system has fundamentally remained the same, and science has just validated and practice has validated time and again the value of the approach. And this is what I want to share with you, how I arrive here and how can you arrive here. So I will start with a brief definition of what the neurofunctional electroacupuncture is for me. And clearly I highlighted the 3 major concepts. It's a peripheral nervous stimulation, it promotes physiological changes, and it has therapeutic purposes. The in-between, you can read it, you will get a copy of the presentation at some point, and that's a commitment. Not today, because I haven't had time to convert the PowerPoint into a PDF, but I will do it later on. So this peripheral nerve stimulation technique is superior to any other form of acupuncture, and I say this without any arrogance, simply from someone who spent decades studying every single method there is to deploy fine solid needles that we call acupuncture needles. And I studied TCM, and I studied French meridian acupuncture, and I studied Japanese acupuncture, Korean acupuncture, and so on and so forth. And I was fortunate as well to study in Canada with my late friend, Dr. Joseph Wong, pioneer in the spreading of a neurofunctional, neuroanatomical, as per his choice of words, approach, and to whom I'm extremely grateful. He was a great man and a great clinician. And his insights, together with what I studied, led me to embrace, in few years, a purely neurofunctional approach because it was more practical and provided superior results every time. And this method, again, I'm presenting it to you not out of any ego, any need to have my system, because I have no need. It was out of necessity purely. And one of the quotes I like a lot is this from Kandinsky, an artist who had a personal evolution that was very remarkable. If you know art, you can recognize a Kandinsky in this painting, which is more abstract, beautiful colors, great harmony. But if you look at some of these others, you will never guess that those are also Kandinskys. And he passed through those evolution periods because of a quest to essentialism. Essentialism means that, like many artists, particularly, he was trying to learn the purest information about color, form, and extract that and portray that. Not because he didn't know how to draw. You can see it here. Many people mistakenly think that abstract artists don't know how to draw. That's not true. They're simply trying to understand the essence of the game of light, if we can call it like that. And that is what I did on our own field. My field was mostly sports medicine, also the treatment of pain, chronic pain. I worked at a chronic pain clinic for years. And that combination of high performance and chronic pain forced me to look into great depth into the human body and to develop a methodology that could work for both ends of the spectrum. Now, I will approach this as if this was a book, the book of Neurofunctional Electroacupuncture Secrets. And like many books, I'm going to start not with chapter 1, but I'm going to start with a preface, which I think is going to be very useful, as in my quest to find the essence of things, I arrived at one fundamental question. Same, this picture obviously is highly recognizable from Hamlet, Shakespeare, the famous to be or not to be, which would be the fundamental question of existence. So paraphrasing Hamlet, I say, you know, what's the fundamental question in clinical practice? Because I thought if I arrive at that, and the fundamental question is not a diagnosis, certainly you can treat perfectly and effectively without ever having a diagnosis. You can treat effectively without ever knowing exactly what was going on. That's something that all of you know because you've all have done it out of necessity, no, not out of a lack of knowledge. So what would be the fundamental question in clinical practice? And the answer was a bit surprising to me because the answer was the fundamental question is where, not how, not why, not when, but where. Because if you don't have a target, you don't have a treatment. I mean, you can have a modality, but if you cannot apply that modality to a patient and to a body part of the patient, you don't have a therapeutic process. So over the years, I discovered this sensational sentence, which is the first sentence of a PhD thesis presented in 1943 by a French physician, also philosopher of science, George Canguilhem. And George discussed in his thesis, compare the pathological state to a normal state and try to answer himself the question, another fundamental question of clinical practice, and is what is normal and what is pathological. But in starting the thesis with this sentence, it really helped me enormously, because when I read it, I was absolutely blown away. I had to stop there, and I don't think I could read that first page for months, because every time I read the sentence, I stopped like Archimedes in his bath and said, Eureka. And it's so simple. To act, it is necessary at least to localize. You need a target. How self-explanatory, how genius is that? So I like to preface things with that reflection, because that reflection is the origin of most of our problems, and we'll see why. Because we're dealing fundamentally with pain problems, pain with movement or pain without movement, at rest, in the morning, this hurts, that hurts. Majority of problems, apart from the visceral problems, digestion, urination, but for the purposes of our presentation, pain with movement disorders, the essence of those syndromes is a discomfort. And that discomfort seems to stem from a body part. And this is the beginning of our problems. Why? Because there is a paradox of pain. Pain is really not a body event, it's a brain event. So if someone administers a general anesthetic to us, they can cut us into pieces with no pain. Pain requires consciousness. Pain is a brain event. It happens above the spinal cord, but is perceived as if stemming from a body part. And this is the sensory dimension of pain. And this is the essence of the paradox of pain, that the sensory dimension of pain does not necessarily coincide with a problem in the particular area of the body where it's felt. Is a central nervous system construct. And pain not only is paradoxical, but is complex because it results from integration of many neuronal activities. Indeed, is recognized that there are three dimensions involved in the experience of pain. The dimension that we just mentioned, sensory, as well as a cognitive dimension. When you experience pain, you think, and you think, have I felt this before? What does this mean, etc. So there is a cognitive aspect that certain areas of the brain deal with. And finally, there is another aspect that's neither sensory nor cognitive, that is an emotional evaluation. How does that make me feel to have this? Yeah, of course, it's uncomfortable, but does it feel me threatened? Do I feel fear? Is very different if you're a fighter in the middle of a fight and then you get hit. And of course, you're going to feel some pain, but you're going to process it differently than a person who feels a pain out of the blue, let's say in their chest, and then all of a sudden get extremely concerned, worried, am I having a heart attack? And maybe it's just an indigestion. So this integrated activation of so many brain areas is what Melsack and Wald call the neuromatrix. And the neuromatrix, very appropriate name after the movies The Matrix, indicates the individual signature of brain activation corresponding to a particular pain experience in a particular individual, and is equivalent to probably billions of neurons and billions, if not trillions, of synaptics activities, indicating the exceeding complexity of pain. So now, all of a sudden, we know that pain is not only false when it comes to indicate, it's not accurate, indicating whether there's a problem or not in a body part, but it can be modified by many factors. But the first foundation that this knowledge should give us, and this is undisputable knowledge and dogma of contemporary neurophysiology, everybody agrees on this, is that our experience of the world is always in the brain activity, and pain is in the brain. And so is pleasure and everything we experience, even though we live in a three-dimensional hallucination. So in theory, we could be happy brains living on shelves, in jars, on shelves from some mad scientist lab, and we could experience exactly what we're experiencing. You know that during brain surgeries, where patients are kept awake, the activation of different parts of the brain makes the patient experience smells, experience sounds, visual stimuli. So very important to remember forever and ever that no brain, no pain. As our friend Homer Simpson exemplified. Now, this first part of the preface needs to be expanded with the second part. The second part is even though pain is a brain event, it is contributed to, I was going to say generated, but it's not generated, it's contributed to by phenomena that take place at 3 different anatomical levels. First, here in blue, you can see the peripheral nervous system and associated tissues. So obviously, nociceptive activity in different body parts will feed the brain. And the spinal cord processes will determine how many of these peripheral signals are allowed to arrive at the brain. And finally, the brain will process signals in many different areas: the thalamus, the somatosensory cortex, the visual, the temporal, the prefrontal, etc. As well as, and this is why there are 2 parts of the brain represented here. One is the cortical, the other is the limbic system. The limbic system are the areas of the brain, such as the thalamus, the hypothalamus, the mammalian brain, specialized in processing signals and evaluating their vital importance, particularly if the signals indicate the possibility of a threat. And what you can see in this pain puzzle I design is that the contribution of the different processes could vary. You can have a situation where there's a lot of activity in the periphery and little activity in the brain. So as soon as the peripheral activity disappears, the cortical and limbic system processing disappears, pain goes away. That would be a situation of acute pain. However, there are many other instances in which, with even decreasing input from the periphery, however, the spinal cord and the brain have a heightened processing of the activity, which will lead to a worse experience of pain without justification based on the state of the peripheral tissues. This is something we know perfectly. There are individuals walking the streets with the same image as other individuals, with arthritic joints, with tears on the tendons, on the supraspinatus tears, etc., without pain. And there are other and with bulging discs, etc. And there are other individuals walking the streets with severe pain, with perfect tendons, perfect articular cartilage, and perfect intervertebral discs. So I like to, and I did that for myself, I like to classify pain not based on duration, acute, chronic. I don't think there's a lot of use doing that, but rather trying to understand the different contributors from these different 3 groups of processes. So the local phenomena obviously include inflammation. Inflammation is a complex set of reactions involving many chemicals like prostaglandin, E2, bradykinin, ATP, hydrogen ions, etc. You can have also different kinds of inflammation: acute inflammation, pathological inflammation from autoimmune, so when the immune system attacks the collagen, like in connectivopathies, or there's a failed repair of the tissue, like in a wound that's too deep and is not able to join the borders, and it has to heal from bottom to top, second intention healing, or pathological changes due to tissue necrosis, presence of cancer cells, etc. There are lots of local phenomena that contribute to the activation of the peripheral nociceptors, including also abnormal interstitial fluid mechanics. And then, to make things worse, more difficult to understand, there are circumstances in which changes in the nervous system magnify the signals that could stem from the local tissues, and that's a phenomenon known as peripheral sensitization, and includes a very important thing, neurogenic inflammation, that's a universal occurrence, and that I will get to in a minute. Now, I could spend several hours discussing the pain puzzle, and it would be a useful discussion because understanding pain physiologically in detail is very helpful when designing a treatment and predicting the response to the treatment, or evaluating the response to a treatment and understanding whether the desired effect is taking place or not, and if it's not taking place, why. But I will not expand myself right now. Maybe there's interest. We'll do a pain puzzle presentation. This is the pain puzzle read now vertically, combining different situations in the periphery with different situations at the spinal cord and centrally. And going from the left column, which is acute pain, so most of the pain experience depends on peripheral nociceptor, we go to the yellow, insidious onset pain, which is the majority of cases in practice. Pain comes out of nowhere. What did you do? Oh, I just turned in the car and my shoulder started hurting. Oh, I just woke up and it was there. Oh, there is nothing major to justify that pain. And we need to understand that when that is the case, don't look into great depth in the periphery, although it'll be some peripheral contributor, but think about more lasting phenomena that have been taking place as a result of irritation of the nerves. And this is something I will emphasize for all of us, and is that the nature of the nervous system is not the one that we're used to hear. The nervous system is not like a telephone central station, signals here and there. Not at all. That is a very old model that was developed in the 50s, 40s, 50s, when telephone central stations were like that. Indeed, the nervous system is a modified secretory system. A nerve is characterized not by generating electricity. Every cell of the body has electricity, every single cell, but by secreting substances in response to a stimuli, whether electrical or not. And that substances have the prefix neuro. There are two main families, neurotransmitters and neuropeptides. And you're familiar with those words, you've heard many times, neurotransmitters, dopamine, adrenaline, noradrenaline, etc. And neuropeptides, there are very many. Neuropeptides are smaller, and they are molecules of local information that modulate the activity of the vascular system, as well as the activity of the immune system. And you have to think that the nervous system, the immune system, and some of the other subsystems in the body are all part of a big meta system that handles defense against external insults, as well as modulation of inflammatory responses, whether those have been generated by foreign invaders, bacteria and viruses, or some internal processes, ischemia, necrosis, cancer, etc. All right. So based on this brief overview of the pain puzzle, I think it's good to come up with the new neurofunctional diagnostic criteria and try to understand when pain is mostly dependent on nociceptive activity. And nociceptive activity is due to specific nerve fibers. We're going to talk about that later on, called nociceptors, which belong to the family of the small non-myelinated nerve fibers, which are the most abundant in the body, or small myelinated ones, either of both the C or the A delta. They end up in free nerve endings without any specialized receptors versus the other thick myelinated fibers that belong to mechanoreceptors and sensory receptors that you know with Italian names, mostly Pacini, Ruffini, Golgi, and that they are encapsulated. So free nerve endings versus encapsulated nerve endings. So we can talk about nociceptive pain. There is no such a thing as mechanical pain. Avoid that terminology. That a pain is triggered by movement doesn't make it mechanical. That indicates simply that there's been a mechanotransduction, but the mechanotransduction doesn't mean that the nature of the problem is mechanical. The nature of most pains is chemical. And if you want to prove that, you just inject any irritant substance in a receptor side of a nociceptor, and then you'll experience pain without the structural damage and without any mechanical issues. So this is all part of the discussion that when we get a case and I analyze, I need you to have in the background, not in extreme detail, but at least understanding when I talk about peripheral neuropathy and self-limited peripheral neuropathy, which would be a case where a nerve has undertaken some changes, maybe on the membrane, maybe on the receptor side, but mostly there are microstructural changes that lead to biochemical changes that lead to changes in the threshold for depolarization, as well as phenomena such as a spontaneous depolarization due to demyelination, damage of the myelin sheath that covers the axons of many of the thick myelinated fibers, obviously not the C fibers, which have no myelin. And neuropathic pain has different quality than nociceptive. Nociceptive pain is typically dull ache, versus A delta fiber, which is also nociceptive, but is sharp. And then neuropathic pain is more of a burning, is more of a electric discharge, and it can be due to wrong activity in the periphery or being already centralized and being central neuropathic pain due to changes at the spinal cord or central changes, which are even more complex. And chronic pain syndromes are obviously well known for being accompanied by many central supraspinal phenomena. All right, so remember, this is the preface, and we could be doing it's a long preface because it's a thick book. The book of neuroscience is not a little book. It's a very thick book, but worth reading. So this is now, we've done the preface. Now let's do the introduction, even before we get to chapter 1. And the introduction, I like to call it the clinical gap. And I put a picture here of the Great Canyon, because that's a big gap between the two sides, excavated by the Colorado River in Colorado and some other states in the US. And the clinical gap is a very important concept because it's based on the paradox of pain. And here I have my own illustration. The concept is very simple. There are many neurometabolic contributors to a pain experience. So let's start backwards. We know that pain is a brain event. We know that it has a sensory, cognitive, affective dimension, and that altogether is called a neuromatrix. And for this neuromatrix to take place, there are many signals that need to pass the different barriers, and also signals that could originate in different parts of the chain of events on the sensory pathways that have 4 main functional dimensions. The first one is transduction. That takes place at the receptor level. The second one is transmission, that takes place along the axon of the neuron. The third one is integration modulation that takes place at the spinal cord. And the fourth is perception, which is part of the neuromatrix. And again, we can spend hours and hours and hours on these four dimensions, and it's important to know enough about them. Just to illustrate how much there is to know, it is like every month the journal Pain, at least when it was printed, I don't know if it's no longer printed or is online, it was thick as this, as the phone book of New York in the old days, very, very thick, every month. So imagine you didn't have time, even if you read every hour of every day, to even come close to read what was studied just about these four phenomena: transduction, transmission, modulation, integration, perception. So remember, what we're trying to accomplish here is not an in-depth understanding of everything, but on the contrary, we are trying to achieve a broad understanding of everything to then direct our clinical attention to the best areas to find a location, the where. That is our quest. Where? The how will stem after from the understanding of the clinical gap. So briefly, peripheral events will contribute to the pain experience. Vascular events, number one, hypoxia is a huge modulator of nerve activity, nociceptive activity. Cellular metabolic events of many kinds, from a simple deficit of vitamin D to a deficit of iron that will compromise the energy pathways, to whatever prevents the full metabolic activity of each type of cell: muscle cell, nerve cell, vascular endothelial cell. Visceral events are very important, a whole world on their own. And obviously sympathetic nervous system, including the events on the ganglia where the neurons are together, whether they're spinal prevertebral ganglia or they're visceral ganglia. Then obviously spinal cord events. So this is the contributors to the pain experience. You're going to have as well, I'm going to forward that to you, a number of articles, in this case 3 articles that were published a few years ago in a journal, chiropractic journal, that discuss in depth the most common contributors to the pain experience, and it'll be a really good reference for you. They are all portrayed in this drawing, and they are listed here. As I've been saying, the number one modulator of nociceptive activity is the local nociceptors at dermatome, myotome, sclerotomes. It could be referral from trigger points, somatic or visceral. It could be from the intervertebral levels at which the neurons affecting the peripheral part come from, or it could be related to the sympathetic pathways, or more importantly, and that's a whole chapter, number 7 here, the kinetic chain. I can talk, and I talk in my advanced programs focus on the treatment of sports injuries, the need to understand the kinetic chain, neuromechanics, how forces are transmitted both at the genesis of movement and then at the absorption, dispersion of reaction forces, particularly the lower extremity, complex bioneuromechanics that we will discuss briefly when we have a case. We'll have a lower extremity and an upper extremity cases at the minimum to exemplify all this, so you can read these articles and understand a lot better. Remember, we are just at the preface and the introduction of this book. So how about the gap? What do we do about it? Well, the first thing is we are aware of it and not do, this is a very beautiful painting, the medieval Dutch. I don't know if it's Peter Bruegel, one of those famous Flemish painters, geniuses. And it was a very well-known topic, the blind leading the blind. And of course, that only leads to the same type of disaster for all of the members of the chain. And this is a topic that I talk about in other presentations that I like, which is the cognitive biases, because I personally observed too much interference of cognitive biases, personality traits, pressure of practice, people being in a hurry, etc., and making mistakes that are avoidable. We all make mistakes. We all going to make mistakes at some point, but the mistakes have to be not terrible mistakes and understandable ones, and not from biases or laziness, but from the intrinsic difficulty of the problems we deal with. So how to close the clinical gap? There was a very nice study here of 41. They pulled 41 studies, and simply the three pieces of advice were: increase your knowledge and expertise, which you're doing, attending this learning continuing education series. Improve your clinical reasoning, which you will be doing by introducing a neurofunctional logic, strong neurofunctional logic into your clinical reasoning, and get help from colleagues, experts, and tools. That's exactly what we are doing. So now, finally, we are ready to start the proper chapters of the book, which in this case will be secret number 1 up to secret number 7. I had 10, but I reduced it to 7, not to do too much. I don't think we'll pass more than secret number 1, but that's okay. As I said, we will continue. I think it's important to build this properly. Some of you may be a little lost, but don't worry about it, because I will return to all those topics. We will talk pain, we will talk the clinical gap, we will put together the picture. So let's go with the neurofunctional electroacupuncture secrets. Secret number 1, and again, secret is quotation marks, just a way of calling attention. There are no secrets. Is logic. The power is in the body, not in the tools. I think that's self-explanatory, but very important to understand, because, and this is something some of you trained classically may lack a little bit, is knowledge about physiology, neurology, pathology, etc. Unfortunately, the complexity of the human body knows no shortcuts to approach it. Everyone dealing with medical problems need to be conversant in medicine. If our training has left holes, and believe me, all training, including medical school, leaves very many holes behind, then it's our ethical obligation and also our passion as clinicians to be filling those holes to the best of our ability. So how do I, or what areas of this knowing the body I want to highlight? Well, I say I'm going to give you a word: neuromodulation, and the other one is neuroanatomy. The other one is easy, gross anatomy and neuroanatomy. And neuromodulation, which is part of, neurophysiology. Neuromodulation is the knowledge of this physiological property of the nervous system to regulate its own activities in response to miscellaneous stimuli, some exogenous, some endogenous. For instance, if the light now changes here in the room, my pupils automatically will dilate if the light goes down, or they will constrict if the light goes up in order to protect my retina. That is a very well-known reflex. That's why I put the little frog here to remember that example. If the heat goes up and my central thermostat feels that I'm heating up above, let's say, 37 degrees, I will start perspiring via sympathetic reflex, sympathico pseudomotor reflex, and I will start secreting water, pretty much, with a little bit of something, but mostly water, in order to lose heat by evaporation of that water. So that's why we have the ability to sweat, but we don't choose. You don't say, I'm going to sweat. We have to go to the sauna or to a warm place in order to trigger that. Those are neuromodulatory responses. Same thing will happen if we feel threatened, and then our heart rate goes up for the purpose of supplying more blood and more energy to the system. And then we will be ready to fight or flight. As you can see, the majority of these responses involve the sympathetic nervous system. That will come back later on, as this is one of the fundamental fundamental phenomenon that takes place in the body, particularly when we experience the unpleasant experience of pain. There's always a concomitant sympathetic activation that could become worse problem than the discomfort of the nociceptive signals initially. The physiology of neuromodulation, apart from the examples I gave you that are straightforward, is a lot more complex and is obviously, like many physiological phenomena, not completely understood. Indeed, as mentioned before, nerves being glands and having secretory responses to stimuli, there are two kinds of general responses of a nerve, which can be named upregulation, meaning something that was produced in certain amount is now produced in larger amounts, or something that it was not produced becomes now produced, or downregulation, something that was produced, it decreases the amount in which is produced or ceases to be produced. And upregulation, for instance, in response to trauma, involve the secretion of neurotrophic factor, which is an inducer of nerve growth. There are other substances that are secreted in order to preserve the regulation of activity at the synapses. So if it affects the synapses, you can say that it participates in the phenomenon of neuroplasticity, meaning adaptations to synaptic activity to facilitate in the future the passage of signals in that synapses. This is part of learning, neuromotor learning. Also, other regulatory responses will affect the electrochemical substrate of depolarization, which involves sodium, calcium, and potassium. And also here, the secretion of superoxido dismutase or catalase or other enzymes with antioxidant defense to protect the cell from excessive presence of electrons. And downregulation, the same. Extremely complex, but important to remember this, and important to remember that in general, we cannot force the direction of the response of the nerve cell during treatments. although repeated treatments will reinforce the direction in which the nervous system is responding, meaning if it upregulates, let's say, the secretion of a given endorphin, then we will become more efficient at secreting that endorphin. And if it suppresses the secretion of substance P or other vasoactive substances that contribute to the pain, to the nociceptive activation, then it will desensitize the nerve. So repeated treatments are like exercise. They will reinforce the aspects involved in the response to that given input. Also, the other part that you need to study in detail is the organization of the somatic nervous system, where it comes from, the concept of the plexuses, cervical plexus, brachial, lumbar, sacral, coccygeal, the intercostal nerves, where, from where to where, what do they do, the correlation between the spinal nerves and vertebral levels. All that is part of important information, because then one of the areas we're going to focus on when we have the case very much is the examination of the axial skeleton, particularly the area over the vertebral column and erector spine muscles. And we will find correlations in the somatic innervation. So we'll see that the C5, C8 somatic level is associated with the shoulder and arm. But also we have to learn about the spinal cord, the origin of sympathetic innervation of the vessels, which is not the same as the somatic levels. For instance, the sympathetic neurons only exist from L1, from T1 to L2. Therefore, if you want to include, if you're treating an elbow, and you want to include a C6, C7 somatic level, you also have to include a T3, T7 reflex vascular sympathetic level. And that is why you need to learn about the neuroembryological development and the corresponding neurofunctional units in the adult, which involve the certain type of tissue associated with a particular nerve, and that received the name of dermatome, myotome, sclerotome. In addition, there is the visceral innervation, which also for the sympathetic stems from T1 to L2, and for the parasympathetic is basically the nucleus of the vagus nerve, which is a cranial nerve that will exit the cranium via the foramen magnum, and then it will reach the corresponding organs. Here is represented. You can see that the vagus nerve goes to the same organs as the sympathetic, and then there is the sacral outflow that serves genitourinary area. All right, I'm going to start the secret number 2 and tell you something that you already know. The majority of responses, clinical responses to needling, are reflex responses involving nerve cells. And this is so important, not only because it validates what we do as a truly science-based intervention, but also because allows us developing systems that produce more consistent results and more predictable results than when we use paradigmatic metaphoric models. So the corollary is we need to learn neurophysiology of acupuncture and electroacupuncture. And this is a whole world that I think everyone practicing this should have a good working knowledge to have a conversation with a health professional and being able to explain the scientific basis of acupuncture and electroacupuncture. So all the literature supports the idea that you need a healthy nervous system, a functional nervous system to support whatever is happening in response to the needling. No nervous system, no acupuncture effect. And for that, you can go to the literature, and from the early 70s, which was the origin of the scientific era for acupuncture, when Bruce Pomeranz, University of Toronto, discovered that analgesia from one rat could be transferred to another rat by injecting the blood, knowing that there were some molecules in the first rat that mediated this analgesia, and those molecules were the beta endorphin and other endogenous opioids, and that started the era of scientific acupuncture. And here you have articles that are not from acupuncture journals, but from regular peer-reviewed journals. In interesting researchers those years, like Libby, Matsumoto. At the end, and I'll give you already the information organized. You remember that there was a property of the nervous system called neuromodulation, and we can, for the most part, allocate response to acupuncture needling to this property, and think that when you put a needle, neuromodulation happens at 3 main levels. There is a neuromodulation complex that we'll study in detail. On the area where you put the needle, that would be a peripheral nervous system territory, neuromodulation. There is a modulation of activity on the spinal cord on the corresponding levels to the tissue where the needle was put, and that's a segmental or spinal cord neuromodulation. And then there are lots of things happening above the brain stem that by definition is above the spinal cord. So it's supraspinal level modulation that affect different areas of the brain that are organized in well-known parts, like the cerebellum, the thalamus, the hypothalamus, and parts of the limbic system, the gyrus cingulatus, the amygdala, etc. So researchers have proven via different studies that these 3 dimensions of neuromodulation are a reality. For instance, one of the most important, which is the peripheral, that by itself would justify the use of needles in areas that are not getting enough blood flow or where the muscle is hypertonic. There's a very well-known axoaxonic reflex that takes place in response not just to needles. These are not things that happen that have been designed just for the needles, can be triggered with other interventions. That's whether pressure or light touch or other forms of energy, laser, etc. Where we're talking about is physiology, neurophysiology. So a famous Japanese researcher, Takeshige, a physiologist, so an acupuncture practitioner, was a physiologist, but interested in the mechanisms. He researched the ability of the needle to trigger a reflex response, relaxation of the muscle that was due to a improvement in blood flow, more blood flow, more temperature, muscle relaxation. And these early studies in guinea pigs have been validated later on. I have another one here from 2002 that was very, very good. And it was a electroacupuncture stimulation in anesthetized rats, also proving that that has nothing to do with placebo effect, that this electroacupuncture will modulate the blood flow on the knee joint. And there were 2 interventions, 5 hertz, 30 minutes, vastus medialis, and they measured mean arterial pressure, and they saw how the microcirculation improved. And also they verified that muscle contraction was necessary during the stimulation to produce that vasodilation that decreased the mean arterial pressure. So that was a fantastic piece of research, and also they managed, I can't remember how, to ascertain that those changes in the vascular behavior were due to a combination of autonomic reflexes, which Takeshige already had done in his research, and a release of nitric oxide, which was a new piece of information that, as you know, is the prevalent vasodilator in the body and totally involved in the response of the vessels and very important for the cardiac vessels. The second group of neuromodulatory responses take place at the spinal cord, and those are several kinds. One that is very well known is the famous gate control theory, and is the notion that activity from thick myelinated fibers, here A alpha, A beta fibers, is processed at the segment preferentially to activity from C fibers. In other words, the thick myelinated fibers modulate the activity of the small unmyelinated fibers, which makes sense since it's more important for the body to know how you're moving, where's the joint, etc., rather than knowing if a tissue is complaining. And so this is the gate control theory, which is no longer a theory, it's a verified physiological fact. Then there are a number of segmental reflexes that polysynaptic, monosynaptic, mostly polysynaptic because there's barely anything monosynaptic at the spinal cord. And these reflexes involve the regulation of muscle activity. For instance, the antagonist muscle relaxes when the agonist contracts. That's reciprocal inhibition, reflex, and also there's an inhibition where the muscle is stretched in excess, then the muscle would relax. So we know that because there's a posisometric relaxation reflex. This is mediated by the Golgi tendon organ. So all these are part of a complex array of spinal phenomena that take place. Also, the convergence is of a stimuli where the viscera, the signal from the viscera and from the somatic part, they end up being processed at the same level, which sometimes generates somatovisceral or viscerosomatic reflex, such as the tightening of the abdominal wall in the presence of an inflamed appendix. All very well known. And obviously, all the somatoautonomic reflexes that we have that could trigger particularly a smooth muscle activity in the gastrointestinal system in response to miscellaneous stimuli on the trunk or on the extremities. And there are numerous studies that show that. Again, I will provide a copy of this, so we don't need to go in detail. Finally, to finish today's first part, chapter 2 of the secret book, there's a very rich array of responses above the spinal cord, and that involves many brain parts, and we know a lot about this. A couple of responses that are worth highlighting is one, the segmental effects of a segmental input, meaning you do something, send signals from one area, and then there's an effect on that area, but the effect goes from centers that are above the spinal cord and via modulatory pathways that are either facilitating or inhibitory, or facilitatory or inhibitory. So this is well known, and these are mediated by monoamines, noradrenaline, 5-hydroxytryptamine. So segmental inputs producing segmental effects, and then what I just mentioned about the somatovisceral reflexes, in this case somatovagal, in which is very well known that a stimulus on the lower extremity produces a response in a viscera mediated not by the spinal cord, but by the nucleus of the vagus nerve. And that summarizes the central effects, which can also be constructed sometimes as systemic, since there is secretion of substances that go into the cerebrospinal fluid and the blood. So needling produces central autonomic responses, central neurohumoral responses, central neuroendocrine responses. And there are many studies proving that. Acupuncture produced changes in patients with angina pectoris, which is a fantastic result. These patients improve their stress test, supporting the idea that acupuncture is not a passive modality, but a neurophysiologically active. It produces effects similar to exercise to a certain extent. And that's fabulous because it's a great tool to integrate with many others, and it should continue to grow and to be integrated in clinical practice for all sorts of patients in need of regulation of the autonomic nervous system. Same thing with the non-specific analgesia triggered by needling in unrelated segmental areas, and the same for the control of symptoms that are very central, such as nausea and vomiting. So summarizing today's first part of the presentation, we can say that neurofunctional electroacupuncture effects can be explained by all these neurophysiological responses and could be summarized as peripheral and spinal neuromodulatory responses, as well as supraspinal neuromodulatory responses and systemic regulation, which, I will leave it here because I really want to spend time on the next one, which precedes jumping, is the end of the chapter, and to jump to chapter 3. So I will stop sharing the screen here and give Sue.
Thank you so much, Dr. Elorriaga.
You're very welcome.
I think to split it like this and to really give a very specific and detailed background is great in creating the building blocks for this series. We have one question to start us off about what is your process when choosing the right amount of frequency to use for an injury?
Can you repeat what is the...
What's your process when choosing the right amount of frequency to use for an injury, or the right frequency?
Okay. In my vocabulary, there are no words of archetypal meaning, because I'm a big student of epistemology. I should have started with that. Epistemology is the philosophy of science, is the study of knowledge. Where does knowledge come from? And it's very useful when you study things epistemologically. So in biology, there is no right or wrong, because biological beings are systems. And also next time I will have a discussion on that. What I practice is systems biology. And a system consists of interaction between elements, and that complex interaction produces properties such as resilience and other properties of the system that make it more adaptable. Therefore, to the surprise of many people, in biology, there is no such a thing as perfection or the right anything. Biology is about adaptability. And there are numerous mechanisms. There is no one way, but many ways. I think the proverbs say there's more than one way to skin a cat. I don't know why, poor cats, but in English you say that. So sorry, because I like cats. But definitely it means that there are many ways of doing things. One of the messages I'm going to quickly put out there is avoid the temptation of knowing more than the system. So my treatments are based on inducing regulation, not in directionally pushing things one way or another. Although I'm guilty as charged today, I did such a thing. But that's an exception, not the rule. So today I did something that's a two-needle technique where I did a set of frequencies. I started with 2 hertz. I play with the 2 hertz for a while, and that targets central release of beta endorphin. Then I increase it to 15 hertz. That touches the spinal secretion of certain dynorphins. Then I put 80 hertz, which is the peak secretion of GABA segmentally. And then I did 125, which facilitates dose descending, inhibitory, and facilitatory. So it was a machine gun approach, and it was out of necessity because this individual has been suffering back issues, mostly from the sacroiliac joint on one side. And then I was able to go with a technique when almost 4.5 centimeters with the 2 needles touching the joint, even though radiologically it's never been proven that it's possible to do that consistently, but at least I'm touching the interosseous sacroiliac ligament, the posterior interosseous ligament, and he felt it. He said, yeah, that's why I feel the pain. So that was my, okay, then I'm in the right place. And I did this frequency just to get all those different neurons and different interneurons to wash whatever was accumulating there chemically for months. And definitely it was a spectacular result. Now that's sort of a trick, and I will share that gladly with the class. But other than that, I typically use one frequency, just 1 hertz. And all I do, instead doing it neurophysiologically, I do it more neuroanatomically, and I'll show how and what the difference. So I touch levels of innervation, but I don't try to push the response of the system in any given direction. I let the system respond the way the system wishes to respond, because most of the time, the desired response is not directly related to the nerves that I'm dealing with, but with the vascular system. So the ultimate goal of most treatments is to vasodilate, improve perfusion, and then let the cells regulate themselves with the new energy and the new temperature that facilitates activity.
Do
So
you ever
that's an
look at the
interesting discussion.
Do you ever look at the response of the body as you're letting it do its thing and try to push it one way or the other just to see if it responds a certain way? Or
I will monitor constantly pseudomotor response on the palms and on the feet. And if I observe an excess sympathetic activation, I would decrease. So I monitor for excess input. If I'm doing too much, I want to know. And sometimes it's impossible because you don't know how the sympathetic system of people are. So I monitor that. And if I feel that it's too much, I turn the electricity off, and then I leave the needles with no electricity, or I remove the needles earlier. So that is the monitoring I do, other than verbally, assess everything okay, are you comfortable, do you feel anything, that part. But yeah, the sympathetic for sure monitor, because the first input particularly could be too strong of a autonomic response. So fantastic question, because it opens up really a proverbial can of worms, but that's where we're here to think and improve.
yeah, it'll be good to kind of continue, and as you build, maybe some of these questions will be answered for people on their own.
Hopefully there'll be more questions and not many answers, because the goal is to ask better questions. And as I said, let nature give the answer.
Mm-hmm.
I'm happy if I can ask the right question, meaning I can address the relevant nerve pathways. Whatever is happening in the body is too complex for me, from my limited resources as clinician, to comprehend, but I don't need to, the same way that the painter doesn't need to control the light, just the effect on the peak. So it's we'll talk about, because it's philosophical, but it's not. It's also practical.
It's always a good way to come into practice with that attitude, I think. Let's see. There's what level of discomfort should a patient expect with the electrostim?
That's a very excellent question. And the answer is very minimal or none. One of my differences with some colleagues is that I don't believe in generating nociception when I'm treating nociception. I think it's unnecessary. And even though sometimes may be unavoidable and minimal discomfort, in general, my rule is every needle should be painless, painless on insertion, painless on stimulation. And if I cannot achieve that, then I would leave those receptor sites for another time when I have modulated the activity around. And that's how I would do it. I would rarely go front head to butt heads with the nociceptors. I don't believe in that approach.
Are there any other questions for now? Let's see here. So if a patient experiences pain with needle insertion, is that related to technique?
I would need to see. I tend to say that a sharp pain from the dermatome is mostly technique related. A sharp pain from the initial contact with the fascia, which is typically mediated by A delta fibers, is also related to technique. You're not compressing the tissue enough. You're not generating a force big enough to really pass quickly that layer. Beyond that, then it becomes a more broader interpretation. It could be that you're touching a vessel that has innervation, and sometimes you see it on the drop of blood when you withdraw. But in general, as I said, in my book, we practice a painless needling technique, two-hand technique, a lot of pressure on the tube, or if I do it by hand, a lot of pressure with the finger, and then quick pushing techniques. We'll review that, like little pushes to pass the layers. Once you reach the muscle, it's easy because the muscle doesn't have a lot of nociceptive innervation. And in general, the muscle is pretty painless by nature, so that's not a problem. So you have to interpret all of the above. In general, a needle that's properly inserted will vibrate painlessly when you flick it. And that's my test. Or also at the beginning of my career, that was the stimulation of the pore. When you didn't have, you just flick the needles during the treatment. That's how we did it for a while.
So if pain is a brain experience, do you have any input about treating the scalp to affect that portion of the brain?
All right, it's a very good question, but don't think as much topographically, because the scalp is near the brain. It doesn't make a difference, let's say, from it's still a peripheral input. Okay, so it doesn't matter that you put it on the scalp, on the hand, on the feet from that standpoint. But the question triggers a very good topic, which is the two main types of neuromodulation available by the body are top down and bottom up. Bottom up, meaning you generate peripheral inputs, whether on the scalp, on the hands, on the ear. Those inputs arrive at the central nervous system and modulate. And then the most powerful modulation that we have available is top down. When I say top down, of course, I point to the brain, but it's top down neurophysiologically, meaning centers of the brain, such as the limbic system, the prefrontal cortex, give signals to other areas of the brain, and those areas modulate they modulate the arrival of bad news, and they filter. So the self-regulation of the brain experience that we have centrally is remarkable. And it's something that probably overlaps with the so-called placebo, but placebo is a bad word, and we can talk about placebo as well. Non-specific regulation of central events is totally legit. And if you can indeed use placebo purposely, you should, because it's fantastic. But anyway, I always combine in my treatments top-down and bottom-up. Top-down, the practitioner just using the right language, just explaining things to the patient is doing top-down. The same way you can facilitate pain by using nocebo effect, by using bad words, by telling people, oh, you're done, you will never dance again, your knee, bone on bone, that, all that is detrimental because it triggers top-down modulation on the wrong direction of nociception. So remember that, and we'll talk about summarize, top-down interventions, which meditation, breathing, parasympathetic, triggering parasympathetic activity is a top-down. And then the scalp specifically, there are two kinds of the scalp. Well, there are several. The Chinese base style, which is just over cortical areas, and then the Japanese Yamamoto new scalp acupuncture, which is simply looking for tender spots. It's a microsystem like the ear. At the end of the day, a combination of both is what I practice with incredible result, by the way. I have some stories. Scalp acupuncture is fantastic, but I use a non-denominational. Like all my treatments are freestyle. I'm a jazz player. And I don't believe the specificity because the nervous system is holographic in design. We can talk about that. And you can send signals. It's like a tree. A nutrient from a root can reach any leaf of the tree. An input from the nervous system can reach any part of the nervous system. So it's a hologram. And that's very useful because that means that there's no one way of doing things. There are many ways.
Is all of this information, the style of information, covered in the McMaster Contemporary Acupuncture course?
Yes, indeed. That's the foundation. What I teach is what I do. I don't teach theory, I teach what I practice. And as I said, I was fortunate enough to work with these athletes on the late 90s. And by the late 90s, I started the program, which has evolved. But the basic methodology remains the same because I discover, next chapter we'll talk about that, what the design is. But yeah, that covers is covering the program.
That's an excellent start, Dr. Elorriaga.
Well, thank you for the opportunity, and thank you everyone for attending. And I look forward to seeing you in the next while.
Stay tuned, everyone. Thank you. Good night.
Thank you.